Welcome back to Innovations in Hypertension Management, Renal Denervation, presented by Albert Einstein College of Medicine at Yeshiva University at CardioCare Live. You are tuned into the second Live session, Sympathetic Activity in the Pathophysiology of Hypertension, with Professor Marcus Schleich. My name is Luis Ruiz-Lope, and I am Professor of Internal Medicine at Complutense University in Madrid, Spain. For those just joining us, I would like to remind you that today's session is a live, interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. It is now my pleasure to introduce today's presenter, Professor Marcus Schleich, head of the Neurovascular Hypertension and Kidney Disease Laboratory at Baker Heart Research Institute in Melbourne, Australia. Professor Schleich serves as director of the Alfred and Baker Hypertension Network. Marcus, thank you very much for joining us today, and I will now hand the program over to you.
Luis, thank you very much. It's a great pleasure to be here, and I was asked or given the task to talk about sympathetic activity in the pathophysiology of hypertension. If you had the opportunity to tune in the previous session where we talked about resistant hypertension, I think one of the things we discussed was that the pathophysiology behind any kind of clinical condition certainly is of relevance in terms of how we therapeutically approach those conditions. And probably the point I would like to make in my presentation is that sympathetic overactivity is very prevalent in hypertension. I believe plays a very important role specifically in the context of resistant hypertension. I do have some disclosures. I have received research support and have consulted in lectures for various companies, as you see here on my disclosure slides. Now, if we talk about hypertension in general and specifically resistant hypertension, yes, we do know that we are actually not doing a very good job in controlling our hypertensive patients. And that is perhaps surprising to some extent, given that we have wonderful medications. We know that lifestyle modification typically works quite well. Yet, if we look at a survey across various countries across the world, we see that rarely do we get more than 50% control rates in our hypertensive patients. And I believe we clearly have to do better. And in order to do so, I think we'll have to understand what we are missing in this context and how this could be improved down the track. And while we've heard from the previous speaker that there's many components that contribute to uncontrolled hypertension, I strongly believe that we have neglected perhaps to some extent the relevance of sympathetic overactivity in many of our patients. And if we take a brief historic look at the advances in the treatment of hypertension over almost the last decade, we have known for a very long time about the relevance of sympathetic nerves and the sympathetic nervous system in general in regards to control of blood pressure. And as you see here highlighted in red, some of the very early kind of approaches to treat hypertension were really based on drugs or surgeries targeting the sympathetic nervous system, such as lumbodorsal sympathectomies performed quite frequently in the 1920s and 30s and later on. And the initial drugs, let me mention ganglion blockers, guanethidine, etc., clearly targeting the sympathetic nervous system. Clearly, we're very fortunate to now have drugs that inhibit the renin-angiotensin system, calcium channel blockers, etc. But I think we should not forget about the relevance of the sympathetic nerves. These are some beautiful illustrations, very old illustrations. This is from a paper of 1935 where they looked at the role of sympathetic nerves, and at the time they typically had beautiful illustrations in their articles. And what you see here on the right panel quite nicely is the sympathetic innervation of the kidney, this mesh of nerves around the renal artery, which then can give rise, of course, to an increase in sympathetic outflow to the kidney with all the consequences I'll discuss in a moment. Interestingly enough, back in the 1920s, 1930s, as I mentioned, one of the very first approaches to treat patients with very difficult to control hypertension was a surgical procedure. The most commonly used procedure was so-called splanchnicectomy. Quite a crude surgery, often carried out in 2 stages, quite a lot of peri-procedural problems and comorbidities, and this was abandoned down the track due to the availability of medications later on. Nevertheless, I think this data are very relevant and important to give us an understanding about the role of sympathetic nerve activity in this context. And this is the main outcome slide from this publication from 1953. Reginald Smithick, a very prominent surgeon at the time who has performed many of those procedures, looked at the long-term outcome of 1,266 cases that were treated with splanchnicectomy, surgical sympathectomy, and compared that with a control group. At the time, the only medication, if you wish, they had was a low-salt diet, and they followed these patients up for quite a long time, more than 10 years. What you see highlighted here is a certain level of hypertension, group 3, and you see surgical versus medical patients, and very clearly 5 years down the track, 80% of those patients who underwent the surgery were still alive, whereas only 30% of those who had placebo, if you wish, or at least a low-salt diet if they tolerated this. So a huge difference in survival rates. And that perhaps speaks to the relevance of this. And if you dive a bit more into this paper, it's really interesting. Even at the time, they had the concept of targeting cardiovascular risk rather than individual risk factors as such. Yes, please.
Can I interrupt you? I think, could you go back one slide? You know that we have been discussing a lot about should we denervate non-compliant patients? And this slide shows, because these patients were non-compliant because they couldn't take pills, which is exactly the same finally. But you know, if you act positively on sympathetic nervous system, does it mean that in non-compliant patients the response could also be positive? Is that correct?
Well, this is a very good point, Luis, and indeed what it indicates is, you could argue this was the first choice at the time because nothing else was available, and I think it confirms the concept that if we manage to lower blood pressure, we will get improved cardiovascular outcomes. The question here would be, this was applying surgical denervation. I'm very sure that a lot of these patients would also have responded quite favorably, of course, to any drug that would have been available at the time. Nevertheless, I really take your point, and it does illustrate that it works quite well, and it would be very useful these days to perhaps perform renal denervation in drug-naive patients to see how well it performs.
This is important, and also because not everybody attain a diminution in blood pressure. So there could be a protection for the cardiovascular system. That could be independent of blood pressure.
Absolutely.
So I think this is a very relevant slide. I'm seeing at this in this moment, and I think it's really very helpful.
It is, and indeed, as I mentioned earlier, the authors, Reginald Smithick, actually referred to this concept, which I really find interesting, particularly in the discussions we're currently having on renal denervation. And if I can just quote, what they're stating here is the prognosis for patients whose blood pressure is lowered after splanchnicectomy is significantly better. That's not surprising, of course, compared to those whose blood pressure is not lowered. However, both of these groups exhibit an improved prognosis when compared with the medical control series. And what their data showed that around 45% of those living operated patients had a significant drop in blood pressure, but around 50% did not have a substantial drop in blood pressure despite the procedure, yet the survival rate was so significantly different. And that perhaps relates to the fact you're just mentioning, that there may be more than just blood pressure, and that blood pressure may not necessarily be the best parameter.